to which we're delighted to welcome Professor James Barlow from Imperial College London's Business School. James is going to talk about, I suppose, the non-existence of a telehealth, telecare market, or at least the below expectations existence of a market in technologies which on paper should be somewhat obvious, obviously useful, obviously economic, but it hasn't yet turned out to be the case. James is really well placed to talk about this based on over 10 years research into telecare, telehealth markets, 100-odd papers on the topic, 4 books, and sort of experience from playing a sort of leading role talking to policymakers both in the UK and Europe who are trying to figure out why we're not over the remote care tipping point. So James is going to talk for 30
half an hour or so,
yeah, something like that, and then hopefully we can have a free-ranging debate and discussion. So good welcome James to the
Thank you.
lecture.
Thanks. Right, well, it's actually, I was just saying to Simon as we were walking over here, it's interesting to be here because apparently there's a bust of one of my ancestors somewhere in Trinity College who was a medic and had something to do with detached retinas, but I've been here a couple of times, but I've never actually found out where the bust is, and but it was about 200 years ago, so 200 years later I'm here talking about remote care. Yes, as Simon was saying, I've spent about 10 years, I suppose, looking at telecare, not really from the perspective of the technologies themselves, but really from an innovation perspective, and trying to understand why something that is seemingly such a good idea is actually quite difficult to get implemented into mainstream everyday life. Before that, I was working on smart homes, and again, that's another story where there have been lots of claims for the tipping point almost being reached. The sort of fully functional smart home where we can switch on the bath from our, using a text message on the way home on the train from our commute. That's never quite arrived either. So there are lots of examples of these technologies that offer lots of potential value, both for individuals and for society, but don't actually get taken up in quite as straightforward a way as perhaps something like a mobile phone or an iPod. So this talk is really based on lots of different bits of research that we've been doing. I mean, there's lots of real, proper academic research behind this talk, which is at quite a sort of quite a kind of high level. This talk, because there's not much sort of detailed theory in here, but it's based on several studies that we've done. And in particular, one thing we're working on is something called the Whole System Demonstrators Programme in England, which is the largest randomised controlled trial ever undertaken of remote patient monitoring. And this is seen by government as a way of trying to develop the evidence base which will kickstart these technologies and move us forward in a sort of kind of step change towards mainstream implementation. So we're part of the team along with University College and LSE and Oxford and Manchester universities, trying to use the WSD program as a way of getting some very, very detailed, hard evidence for both the economic benefits, but also the benefits in terms of clinical outcomes, and in our case, and Manchester University's case, being able to say something about the organisational barriers and barriers in terms of face-to-face frontline care staff and how they interact with these technologies. Anyway, so that's what so the talk is really based on lots of research. What I want to do is to say something first of all about what I mean by remote care, because different people have different understandings of what it means. So I think we all need to get onto the same wavelength here. I'll then talk a little bit about the reasons why, first of all, the kind of history of all these tipping points and why we never seem to quite reach there. And then I'll say something about the reasons why I think that's the case and where we need to, how we need to move forwards. So, first of all then, a bit about the terminology. All those terms are really used interchangeably in the literature and in everyday parlance, ready to mean one thing: the remote delivery of health and social care using information and communication technologies. And is it telemedicine? Is it telecare? Is it telehealth? Really, for me, it doesn't really matter. But there are some fundamental differences between, I would argue, between telemedicine and I haven't got a pointer here, but down the bottom there, those two bottom rows, really are what it's all about. Telemedicine, for me, is all about a B2B, so business to business, professional to professional service, connecting up experts. The patient may or may not be present. Whereas telecare, telehealth, remote care is much more of a B2C model. It's delivering services direct to individuals out there in their own homes, in the community, possibly in real time, possibly 24/7. And the bottom row is the key thing, really. In telemedicine, and there's lots of that around the world, lots of examples in countries like India and elsewhere. It's relatively straightforward to set up. You're just talking about an end-to-end, lots of professionals communicating, perhaps by video, or perhaps sending some images and using that for diagnosis or second opinion, compared to telecare, which is much more complex and therefore harder to implement. I'll come back to that in a second. And it can do all sorts of different things. There are probably 3 or 4 different applications that can be grouped together in what we call remote care. Some of it is about the home itself and making sure the home is safe and secure, monitoring things like gas and electricity and the bath and whether they've left the door open and so on. So it's about mitigating risk. Some of it is about monitoring the individual and vital signs or activities of daily living. And that might be about risk, but it could also be about prevention and intervening in a more timely way if there's a problem. Over on the left-hand side there, some of it is about delivering information and communication to people more effectively, providing health advice, developing virtual self-help groups and so on. And some of it down the bottom could be about the smart home, electronic assistive technology, so devices which allow people to, disable people, for example, to function more effectively in their own home. And if you can link that into lifestyle and activity monitoring, then potentially at least you can add a lot more functionality to those kinds of devices. So there's a whole bundle of different applications grouped together around what we call remote care. Now, conventionally, there are various ingredients of success which are said to you need to have to tackle in order to deliver and implement remote care. And we have to tackle the organizational arrangements for delivering it. And we have to put in place adequate resources. There has to be some sort of business case as well. And that's sort of conventionally seen as being the key factors behind successful mainstream implementation. But I would argue that actually that's fine, but it's incredibly complex, remote care. And it's not only a very complex environment. Health and social care delivery in the UK and in Ireland involves multiple stakeholders, strange sort of perverse payment and reimbursement models, lots of different professional bureaucracies and cultures and so on. So when you add that into the mix, just dealing with those matters becomes much more difficult. And added to that is the fact that remote care itself is not a simple, neat innovation. It's not technology and it's not services. It's both. It's not a neatly bounded, simple innovation like a new pill or a new medical device for cutting you open more effectively. It's something much more complex than that. There are no NICE, the National Institution for Health and Clinical Excellence, in England and England at least, not Scotland, produces the guidelines for implementation of new medical innovations, and there are no NICE guidelines for remote care. And as I'll come back to this in a moment, but the evidence base for remote care is contested. So it's often sold on the basis of faith that it will work, that it will do the job, that it will be beneficial to everybody. Evidence for the benefits is something I think we're actually strongly lacking, and that's beginning to impede implementation, as I'll say in a minute. So that's a little bit about about what remote. And the basic point is that it's not a simple innovation. It involves technology and organisational and service change, and the evidence base is contested. It's been around a long time as an idea. So what progress have we made in actually deploying it? Okay, so its origins go back many years. Certainly back to the flying doctor model in Australia and elsewhere, and even before that. And that's an article in the Lancet. And Nick Robinson, who mentioned this to me, I didn't believe it was actually 1879. I had to go back and look at the archives of the Lancet to actually check that was actually the date. But this is a story about a woman in Mayfair, and this is America actually, I think, whose child was ill with a cough, and that she phoned up the GP, and the GP said, hold the phone to the chest, and diagnosed it wasn't croup. The usual joke that goes with this is that even in 1879 it was impossible to get GPs to come out to do house calls at night. But anyway, as an idea, it goes back a long time. And certainly for the last 15 years, people have said, well, we're at a tipping point, give it another couple of years and it'll be part of the mainstream. There are many case studies emanating from industry, from companies that have an interest in selling products, and from government, and local authorities and Department of Health and so on, which all want to promote it. There's even a sort of momentum now building up from the consumer side. That's an article from which is the main consumer products magazine in the UK. There have been two of those in the last 18 months or so, basically saying, there are these technologies out there, you should be asking your local council and local health authority to provide you with these. And it was mentioned on Today, which is the main sort of news programme on Radio 4 by the Confederation of British Industry about a month or so ago, just completely out of the blue, just said, we need telecare. That's an example of an innovation that's going to help UK economic crisis. So there is roots, momentum building up, that there is awareness percolating into not only the general public, but in general industry as well. And I think it's also clear that certainly its time has come in terms of the way healthcare, social care delivery is evolving in England and most other countries as well. And if you just look at the UK, I mean, we've a period of sustained investment in healthcare. We now spend £110 billion a year on the NHS, plus another 30 billion or so on social care from public expenditure. It grew by something like 60% or 70% in real terms in about a 10, 12-year period. But then, of course, we've got the credit crisis, credit crunch. I know it's bad in Ireland, but it's also bad in the UK as well. And we've also got this sort of perfect storm, as people have called it, of huge escalating demand for care services, from the rising incidence of chronic disease, demographic change, ageing population, all the usual things we know about, but also new innovation coming in, new drugs which allow us to do new technologies which allow us to do more things, driving cost inflation in healthcare. So there's this huge sort of crisis brewing, which means we've got to find new ways of delivering care. And innovative new business models for health and social care are now certainly on the agenda in the UK. They will involve not only new thinking about new types of service or how we deliver existing services in new ways, but clearly new ways of using technology and new configurations of infrastructure as well. So new ways of thinking about physically where care is delivered, away from expensive traditional settings like hospitals, nursing homes, and back into the community. And remote care is clearly part of that agenda. In the last 10 years in the UK, we've seen a huge investment, 30, 40 billion pounds going into new healthcare infrastructure, physical infrastructure. But now really the time has come to start thinking about the home and the community. And remote care is very much part of that agenda in the UK. So, point is really that the omens are right. The financial crisis is certainly opening up a lot of debate about how we can use new technologies and think about new kinds of model for delivering care, and what the role of the underlying built and technical infrastructure for healthcare is in dealing with the economic crisis. Right. What then is the reality in the UK? Everybody wants it. How far have we gone down the road of actually introducing remote care? Well, one problem is we don't even know how much remote care there is out there. If you look at the Telecare Services Association website, which is the leading trade association representing providers of community alarms and telecare type services. On one part of their website, they'll say there's 1.75 million people with a telecare service. On another part of the website, they say there's 1.5 million. So even the TSA doesn't actually know and isn't really consistent in its understanding of how much is out there. The Care Quality Commission in England did a census in 2009, which 639,000 people. Official returns for the Department of Health's Preventative Technologies grant suggested that around 145,000 new recipients of telecare would there'd be 145,000 in 2009, 2010. As I said earlier, I think the UK is arguably more advanced than most countries. Certainly, there's been a lot of thought. First of all, what we do in terms of reshaping healthcare services. Second, putting a lot of money into developing technologies, supporting universities like my own and others, in actually coming up with new innovative technologies, and thirdly, in pump priming their implementation in the real world. But despite all that effort, and despite we know that the vast majority of them fail to survive the initial pilot project phase. There are lots of pockets of excellence, lots of examples of good things being done, but they tend to stay pockets of excellence. And as I said, the pilot projects aren't sustained. So why has there been such a lack of progress? One thing we do know, again, is that probably most of this is not to do with the technologies. Certainly there are engineering issues, there are issues in terms of usability and the interface, and reliability and systems integration and so on. But the bulk of it, I mean, in the 10 years or more I've been looking at this, probably 90% of it is around organizational factors and around who pays for what as well. I don't know what it's like in Ireland, but certainly in the NHS there's been constant reorganisation in 20, 30 years, in fact, but you know, even in the last 10 years there's been a couple of major reorganisations, and we're now going through another one. Certainly there's plenty of new ideas, plenty of innovation in healthcare that are tried out without any evidence at all. And that cartoon is basically about strategic health authorities doing lots and lots of new, silly things without really knowing what they're doing. Somebody's done the gold standard randomized controlled trial. I don't think you can do that anyway, but to develop that evidence base, economic evidence base, we've still got to carry on trying out new ideas, and eventually some of those will stick. So I am positive about it. I do think we are actually at a tipping point. I mean, I'm sure in 10 years' time, maybe somebody will be talking about it and putting a quote from me up there. But I think we've moved sufficiently far down the road now to actually build up a sort of momentum for things to happen. And I am positive, and I think, you know, we all need to be going out there and making it work. So that's me done. Thanks very much.
James, shall I let you take questions rather than have me as an intermediary?
Yes.
Just a very stimulating talk, and very relevant for what TRIL is interested in. Just in terms of what we're talking about healthcare. And my own kind of view is when you're talking about healthcare, and you're talking about three separate domains. You're talking about the domain of a healthcare provider, the domain of the healthcare recipient, and you're talking about the domain of the funder, or the person who is to resource all that. And there are undeniable tensions and competing interests and vastly different pressures and influences upon those three domains. And unless you're able to marry and resolve those tensions, those conflicts, the sustainability of any model of healthcare is completely in doubt, whether it's remote or whether it's care. And therefore, I would kind of suggest that for sustainability and for long-term kind of impact, that the three different domains, they need leadership, they need to have shared values in order to kind of to resolve those conflicts and ultimately, because there are, if you order the slides you put there about the doctor being telephoned by the patient,
yep.
There's obviously a tension there about how do you charge for that, you know?
Yes.
So unless we resolve those, whether it's remote or whether it's at home care, I think it will always be a stumbling block.
Yes, no, I think that's right. I mean, there's balancing these different interests has always been the problem for governments. I mean, to some extent, I would argue that the leadership needs to come from the top. You know, in England, government has got to say, just we will do this, and it can set it can shape the landscape, set the parameters. It can put in place mechanisms to reward local health authorities that are perhaps spending a bit more money doing this in the short run, given that they're probably going to be incurring additional costs and running existing services alongside the remote care model. So I think it partly needs to come from the top. But equally, though, I think we haven't really begun to explore the sort of bottom-up and privately driven models that could be out there, consumer-driven models. And certainly in the UK, it's always been very difficult for private providers to know where to insert themselves because we have a sort of monolithic NHS system and it's free at the point of delivery, and it's very difficult for anybody to come along and say, okay, we're providing this service, but you've got to pay for it. So, but I don't think we've. I think there are certainly points where private models could start to emerge. So you are paying a private provider to monitor your aging relative who's living 200 miles away. And the beginnings of that sort of, a few companies are sort of testing the water there, I think. But certainly the leadership, I think, and the structuring of the whole sort of landscape has got to come from government, really.
You mentioned just at the end of your talk that you were involved in the process of trying to evaluate cost effectiveness. But you said to hear a little bit more about that.
Well, in the whole system demonstrators program, there is I'm not actually part of that team, but they are trying to measure the cost effectiveness of the telecare interventions in 3 trial sites, and it's been set up as an RCT. It's an incredibly complex trial. I don't pretend to know the details of the trial. I can't talk to you about the details of the trial design because it is incredibly complex. But what they've found, and I know what we've found when we've tried to do this, is that actually getting a handle on costs is very, very difficult because nobody actually knows what the service, what the technology actually costs, or even what the cost of what they're doing at the moment is. I don't know what it's like in Ireland, but if you go to a health trust in the UK, there is no real accurate data on the cost of different services. So doing any kind of economic modelling is very difficult. What we've tried to do in our work is use simulation modelling. So you're building a kind of a model of a bit of the care system in collaboration with the different groups that are part of that care pathway. So there's a sort of shared model that everybody understands. And then using that to ask questions about what happens if, say we change this bit of it, so we introduce remote patient monitoring here. What does that mean in terms of the different bits of the system? And then you can sort of infer what might happen in terms of flows of people, patients through the system, and what might happen in terms of costs that way. And that's been quite instructive, actually. And it's as I say, it's sort of shown that the overall cost savings are not that great, but perhaps to one individual part of the system, it makes a big difference. We did it for heart failure patients, and what that showed was, I mean, it all depends on the assumptions you make about how effective remote patient monitoring is, but using the best evidence from the various trials of remote monitoring of heart patients, we were able to model the potential impact at a national level. And what we showed was that it didn't substantially reduce the number of bed days in hospital, but it did sort of stabilise the increase in demand over a period of time. So you're sort of taking demand out of the system that way. And clearly each of those bed days is expensive. And so the cost is benefit side is very, very difficult to do any work on, really.
Question. Like talking to the ICT, so that has some very interesting kind of a private entity driving this approach. So we'd be looking at consortiums, the pharma industry,
yeah,
and look at business models and pay-per-use type models.
Mm.
The elephant in the room, I guess, is the data. Who owns the data? And we've looked at what type of data.
Yeah.
And it's actually even scary from our point of view is that who should control owning this data? Because from our point of view, we know from personalized medicine in the future, pharmaceutical industries is quite lucrative to make a lot of cash.
Yeah. Yeah.
Any views on that? We know in the European context.
Yes. Yeah, I mean, well, as you said, it's clear that data does have a value. I mean, and it should sort of free up. Yes, I mean, you should be able to use that data as kind of leverage to get things done. But I mean, the pharma industry has always sort of, in my experience, has always kind of expressed interest in these technologies. And clearly it sees it as a way of getting more rapid feedback on how particular drugs are performing and using that as a way of speeding up the drug design process and so on. But they've never really, I mean, maybe it's different in your experience, but they seem to talk a lot about it, but certainly in England they've never really kind of got deeply involved. But I think there may well be a role for them somewhere in the supply chain. In England, there's a big sort of the data problem is I mean, first of all, we've got the whole sort of national programme for healthcare IT, and nobody really knows how much we spent, but 15 billion, is it 12 billion, is it 20 billion have been spent on trying to introduce an electronic patient record and other e-health applications. So you've got all that kind of world. You've got GPs who've got their own, I mean, they've all got electronic patient records. And then, of course, you've got 300 community alarms call centres who collect data on falls and pendant alarms and so on, but nobody is really trying to glue all that together. And I've been pointing this out to the Department of Health for about the last 5 years, and I don't think anybody's really taken ownership of how you stick it all together. So yeah, I mean, without good data and integrated data, I think you're missing a trick here. But it's even worse in Japan. As I discovered a month or so ago, when I was doing some talks in Japan, and the only thing that really obsesses Japanese healthcare system now is having a single patient number, identifier number, because there's no sort of primary care. Everybody basically goes to a hospital if they need healthcare, but you can go to any hospital you want. And of course, a new record, and people go to different hospitals for different, because they know this particular doctor's good for this thing, and this one's good for this thing. So there's absolutely no connection at all between patient records in Japan, and they were telling me that this is the number one thing that's preventing any kind of sort of move towards community care, let alone telecare, remote care. So it's a big issue.
Do you think it's an issue? I was intrigued that for the last third of your talk you talked about it all the time.
About it, yes, yeah, it.
And yes,
what is it?
Yes. You showed that really complex diagram, saying that it meant a huge number of things.
Yeah.
So it's very difficult to expect it
Yes.
to be acceptable.
Good point. Yeah.
So, for example, an example would be scoping. When scopes were invented, surgeons and phonetics didn't go up and down every single orifice in the body. They did the most common one first. They went down, they did one procedure, and then compared it with one. And so those papers were published, and they were done all over the world. And then so on, so on, so on. So now there's hardly surgery because it's been completely accepted. So surely,
yes. I think that's yeah, you're right. I mean, you kind of picked me up on something there, which I'm just thinking about now. And I mean, I think there are, as I say, there are lots and lots of different things there, and those are beginning to become implemented at different rates. And certainly in the UK, I mean, we have 30 years or more of the top one of those. Starting out with a sort of community alarms service. There probably are 1.5 million people, as the Telecare Services Association says, at any given time with some sort of telecare, even if it's just a simple pendant alarm. So in a sense that you could argue that is mainstream. NHS Direct, the kind of online or telephone-based advice and support system. I mean, that has, I don't know how many million hits per month or calls per month or whatever the figure is. But that again is an example of remote care. And I think, as I said, there are lots of sort of teleologies there. There's teledermatology, teleradiology, teleoncology, teleophthalmology. I mean, a lot of that is pretty well mainstream in lots of countries, particularly where you have a dispersed, low-density population and difficulties in gaining access to healthcare. So bits of it. I think you're right. Will be implemented at different rates, and some of it is probably still, a lot needs to be done. But equally, a lot of it is probably more or less mainstream now already. I suppose what I'm really talking about is the kind of real-time monitoring of people in their homes, whether you're monitoring vital signs or activities of daily living. That's where a lot of the effort is going, both in policy terms and research and development. And that's the bit that's really difficult, I think, because it does cut across so many bits of the care system, and you have to get...
It's something like, say, other people took their drugs or not. And there's all sorts of stuff.
medication reminders and so on. Yeah.
And you get these boxes and you time
Yeah.
and
Yeah.
all that. That's stuff you can actually measure. And you can measure the cost of it, and you can measure
Yeah.
the savings, you can measure what's happening, and you could actually measure a physical sign. So whereas all of those other things that are in that first diagram are all a little bit difficult to measure the
Yes.
cost of. And
Well, there's so many things changing at the same time, and
whereas if you've got
Yeah.
definite
Yeah.
measures of cost and benefit, then it's
Yeah.
easier to build up a case. So rather than trying to spread efforts around
yeah.
more points of the compass, it would be better to focus on.
But I think that is happening. You know, different solutions are being developed by different health trusts, different social services authorities, depending on their own specific needs. So, you know, a particular health trust wants to focus on diabetes monitoring, and that's where it will you know, initially make the investment in monitoring. And that's beginning to happen. The WSD, the Whole System Demonstrators, has been rolled out in 3 different sites, and they've focused on COPD, heart failure, and diabetes. Those tend to be the sort of the big 3 that are usually focused on. But you know, other authorities are trying to do it for people with dementia or stroke care or other things. Yeah.
Just we spoke about healthcare first of all. Healthcare must always be delivered by healthcare professionals. And healthcare isn't a static quantity. It's something which is continuously evolving. And therefore, it does strike me that a huge amount of thinking is around business cases and around that domain of things. But I think what we need is kind of, in order for this to be embedded as a way of delivering healthcare, it implicitly must involve not just the stakeholders, but actually as drivers, the actual healthcare professionals.
Yes. Yeah.
They need to see explicit and accepted value within key components, because, for example, there are 24-hour heart monitoring, and that's obviously accepted because it has a specific outcome and it's specifically clinically applied to the situation. Unless the clinicians are 100% on board, part of the development of it, I think a lot of the other strategy just won't stick because it won't affect the underlying culture of healthcare professionals.
Yeah, no, that's certainly becoming clear, I think. And again, you know, that's where the evidence base does come in, because clinicians have a different, you know, they have particular views about what counts as good evidence. Well, GPs are different from consultants in hospitals, so and who are different from nurses. So telling the story in the right way for the right group, I think, is very important.
Which ingredient of the recipe, like which of the 3 ingredients do you think, in your opinion, is most lacking in the way of organisational change, resources, or even the business case?
Well, I think resources are a problem. My argument to, you know, a lot of these people these groups who've tried it out, health trusts have tried it out, they've done their pilot project, they've probably had some funding to do that. I've often said to them, look, you know, if it works, why aren't you rolling it out? You know, why are you asking for even more money from the Department of Health? You know, because, you know, if you think it works, then you should be just doing it. And their argument is always, well, fine, but you know, we've got to run the existing service whilst we're rolling it out as well, and we need some support. It's going to cost us more money, and so I think that there has to be some recognition that innovation does cost in the short run. But I think getting the business case right as well is important, and that's where we're sort of lacking, I think, now. It's very difficult to persuade the finance director of a health trust to put their hands in their pockets and spend £1 million and rolling it out. You know, why are you asking for even more money from the Department of Health? Because you know, if you think it works, then you should be just doing it. And their argument is always, well, fine, but you know, we've got to run the existing service whilst we're rolling it out as well, and we need some support. It's going to cost us more money, and so I think that there has to be some recognition that innovation does cost in the short run. But I think getting the business case right as well is important, and that's where we're sort of lacking, I think, now. It's very difficult to persuade the finance director of a health trust to put their hands in their pockets and spend £1 million and